So as I was saying, we are looking at the gastrointestinal tract, and it's a system that comprises of the uptake of food, breaking them down, absorption of nutrients for cellular respiration, and then ingestion of undigested food substances that will be expelled through the anus. And I said it's a muscular alimentary canal, which is made up of both smooth and then skeletal muscles that are involved in all this rigorous exercise to make you and I living. So the contents of the GIT, we have the mouth, which is where food is ingested through, the pharynx, which is connected to the mouth, the nose, and then the trachea, as we saw in nasopharynx, oropharynx, and then laryngopharynx. And then we have the esophagus, depending on the style of your speech, whether British or American. You can mention it as esophagus or esophagus. So the stomach is the most dilated part of the GIT, where food is actually churned into chyme. And then we have the small intestines, that is the most longest part of the GIT, the large intestines, which we can see over here, and then the anus, where there is expelling of undigested food substances. Attached to this whole tract system, we have accessory digestive organs, which are the mechanical breakdown of food tools, that is the teeth and then the tongue. Then the chemical breakdown of food, that is the salivary glands. You can see the sublingual below the tongue, submandibular below the jaw, and then the parotid glands. So these are the expose of this parotid, or sorry, salivary glands. The gallbladder, which excretes bile or secretes bile for emulsification of fat. The liver, which is also essential in the production of bile, other substance. And then we also have the pancreas, which secretes pancreatic amylase when it comes to the GIT section for other substances. So looking at it, we have the tongue. You can see the parotids, the esophagus, the stomach, the duodenum together with the jejunum and the ileum make up the small intestine. And then we have the colon, we have the ascending colon, the transverse colon, and the descending colon. The sigmoid colon together with the rectum make up the large intestine. And then the anus as the overall expeller of undigested food materials. So what is the digestive process? The very first thing is to ingest food. While food is ingested, there is a mechanical breakdown, that's mechanical digestion, where we have chewing being done in the mouth, or mastication done in the mouth by the teeth. And then this is going to be propelled into the stomach by the esophagus via the motion of peristalsis. And then we have churning of food into chyme in the stomach. And then this food is going to be what? Breaking down severally in the duodenum. So all this that is being done here is some form of chemical digestion, where you have chemicals being released into the food and then breaking it down for the minute component of these foods being released, or the macro component of this food being released. So the proportion is actually by swallowing food, and peristalsis. Mechanical digestion is done by chewing of the food, churning in the stomach, and mixing by segmentation in the small intestines and the stomach as well. Chemical digestion, this is when enzymes come in to break down the food, And then absorption is actually when these broken down foods are taken into the cardiovascular system to be used by the tissues for respiration. And then we have a vice versa removal of tissue waste into the bloodstream. And then elimination of undigested substances in the body is egestion. So this is just to show us the overview of the GIT functions or processes. I can ask you, take note, I can ask you to describe anatomically, and the word is anatomically, how digestion takes place. If you go and then you said, oh, food is masticated in the mouth and then saliva will be released, you are just mentioning the chemical process, you are off. You get maybe just 5% or 10% of the mark. However, this is how you tackle it. You need to tell me what is happening in the mouth as the food gets into the mouth. How is mechanical digestion done? What are the tools for mechanical digestion? You should mention the teeth, the tongue, how they roll the food into bolus and everything. How then the salivary glands will also release their saliva. And this saliva, you should also tell us the salivary glands, the sublingual, submandibular, and the parotid glands, they are secretions. When it comes to the stomach, what you are also doing there, esophagus, how is the proportion done? Which of them is it by the muscularis externa? The muscularis externa, how is it doing the peristalsis movement? So this is how you approach anatomical digestion. You don't only look at the chemical breakdown, which is physiological sense. So anatomical digestion is basically how the structures are involved in the breakdown of the food and their absorption. So I expect that when you get to the duodenum, where most of the absorption is done, you need to state the cell, how the cells are able to pick up the food substances into the body. It's not just a matter of eating the food without knowing how the food is being absorbed. All right. So when we take most of the digestive tract is seen in the stomach, or most of the times we confuse abdomen for stomach. So the stomach or the abdomen is actually divided into 9 regions, and I would want you to go and look out for the names for these 9 regions. The 4 regions, I've placed the names here, but the 9 regions, and then the essence of dividing the abdominal cavity into 9 regions. For instance, when you look at the left hypogastric layer, when you have a pain there, you can say that, oh, so far as it is this hypogastric layer, probably I'm looking at the stomach being affected and then maybe the right lobe of the liver. That is how it goes. So that when someone is mentioning, oh, the left part of my stomach, even though the person is referring to the abdomen, the left part, okay, if it is the left part, what section am I looking at? What organs are there? Oh, okay, if it is, maybe it could be appendicitis. So that is how you do the evaluation. And then when we come to the most common one, which is the 4 common one, we have the right upper quadrant, the left upper quadrant. Also, these are all channeled to the deviations. So aside that, we have the epigastric, the periumbilical region, the suprapubic, and then the flancus region. So these are some of the most common ones. I asked you to go and then look at the divisions pertaining to the 9 regions, and then there are clinical correlations. This I will put on the LMS, and then you will have to do it as a home assignment. So a brief on the histology to bring out, I'm not going to teach more histology here, just a brief on the histology those in A, you are very much conversant with the histology of the GIT. So the histology of the GIT is made up in 4 layers. We have the mucosa, which is made up of the germinal epithelium. Either it is stratified squamous, non-keratinizing, or simple columnar epithelium, microvillated. And then after that, you have the lamina propria. Within the lamina propria, we should have some glands within there. And then you have the muscularis mucosae, which actually does a localized movement of the mucosa itself. After that, you have the submucosa. And then this submucosa has a lot of glands together with blood vessels that allow for what? Exchange of materials. Then within the submucosa, we can also have the Meissner's plexus that allow for nervous innervations or innervations there. After that, you have the muscularis externa, which is made up of the inner circular muscle and then the outer longitudinal muscle. And then within this muscularis externa, we have this connective tissue layer, which has nerves and some blood vessels, which gives information to the muscularis externa. And then this plexus here is known as the myenteric plexus, as compared to the Meissner's plexus that we found in the submucosa. So all these things are the enteric innervations of the body. And then outside this, we have the connective tissue layer, which is known as the adventitia or serosa, depending on where it is found. If it is within the body cavity, it is known as serosa. But when it is attached to the body wall, then we call that as adventitia. So this is just to show the mucosa, which I have already explained. Most of the times, histology is going to explain more of this. So I don't have to waste so much time on this. I've already given you the summarized information on this. So the last layer, which I said is the adventitia, is normally also known as the visceral peritoneum, especially the serosa. I'll explain why it is known as peritoneum. Okay, so the exception is that pass not in the peritoneal cavity without adventitia, as I said, so they will not have serosa. And what you should know is that we have the adventitia, the esophagus, together with the anus, they are having adventitia. But the stomach and the duodenum and the large intestines, they would have the serosa because they are found in body cavity, that is the abdominal cavity. So this is also just to show us more of the muscularis externa, which shows us the inner circular muscles and then the outer longitudinal muscles. They are trying to show us how they appear here. And one thing you have to know is that they are non-striated muscles, non-striated muscles. Now, nervous or innervations to the GIT is actually done by the enteric nervous system. When we say enteric nervous system, this is the GIT, the gut's own innervation, where you have the visceral plexuses within the gut wall, controlling the muscle glands and having sensory info. Example of these are the myenteric plexus and then the Meissner's plexus, which is known as the submucosal plexus. Then we can also have the autonomic input, where you have parasympathetic, which will stimulate digestive functions, and sympathetic, which will inhibit digestive functions. So when you finish sleeping, when you finish eating and you come and sit in my class and you are sleeping, what it means is that the parasympathetic nervous system is in action. And what is happening is that more of the blood is going to be channeled to the digestive system. Hence, small amount of blood will reach the brain. Now, when there is small amount of blood reaching the brain, what it means is that the amount of glucose supplied to the brain is lower. Hence, you are going to have a lower or a less firing activity from the brain. And that is going to give you the effect of reducing all sympathetic activity. And then you will begin to feel sleepy. So it is not very good that when you finish your 3 balls of banku or whatever food you've taken, you should sit in class. Some other things we need to know is the peritoneum, where you have the serous membranes of the abdominopelvic cavity. So the peritoneum has 2 parts. You have the visceral peritoneum. The visceral peritoneum will cover the internal organs within the abdominal cavity, while the parietal peritoneum will line the body wall. So anything found between the visceral peritoneal layer is known as the peritoneal cavity. So we'll be looking at that very soon. So the very first thing we saw is the peritoneum, which is serous membranes of the abdominopelvic cavity. And then the next thing we are going to see is the mesentery. Now, the mesentery is also a peritoneum, but this peritoneum is folded into double layer. And then this mesentery extends to all digestive organs. Now, let me try to explain the mesentery. I don't know which of those of you who have killed a fowl or goat before. Now, when you get to the abdominal section, you realize that you see some slimy whitish substance. That slimy whitish substance, which is trying to hold all the organs, the intestines, the stomach in place, that is the mesentery, or we call it the mesentery. So they hold organs in place where most fat storage is being done, where you have most route of circulatory vessels entering and coming out. Mostly they are dorsal, and then they may also have ventral mesentery. So the ventral mesentery, we can see it from the stomach and the liver. And then when we have these ventral mesenteries, they can eventually form into something we call the lesser and greater omentum. So we'll be seeing the omental bezier very soon. So some mesenteries are called ligaments, though not technically such, because they connect the liver and then the stomach or the organs in place. So looking at the diagrammatic presentation, so this is the posterior dorsal body wall, and then this is the anterior wall, and then we can see the peritoneum. Now the outer cream one is the parietal peritoneum, and then the inner, I don't know what color is that, is the peritoneal cavity. The black one is the visceral peritoneum. So you can see how the visceral peritoneum comes out. And then this is the alimentary canal. So anything that surrounds the alimentary canal, we call it the mesentery. Now that mesentery is a double fold of the peritoneum. So we have the dorsal mesentery and we have the ventral mesentery. And then these mesenteries will actually fold to connect the organs within the abdominopelvic cavity or the abdominal cavity. So this is just to show a transverse section of the abdominal cavity. And this is how we see it when we look at the retroperitoneal side. So looking at a lateral view, this is just to show all this yellowish substance that we see is actually the peritoneum. The yellowish one is the parietal peritoneum, and then the blue one, as you can see, that line blue one is the visceral peritoneum, and the space, these are the peritoneal space. Now you can see how they fold in just to surround each organs within the abdominal cavity. And when they surround it, each of them becomes what we call the mesentery. And then depending on what they cover, they all have their mesentery. So we'll be looking at the names for this mesentery. We can have the ligamentum, jejunum, and all those things. We'll be looking at them very soon. You can see this mesentery covering the colon, so we call it the mesocolon. So the one that covers the transverse colon is known as the transverse mesocolon. Now, when we come to the stomach, we call it the omentum. The omentum. Now, when you look at the stomach and then the liver, you can see that something connects the stomach, the peritoneum, the mesentery that connects the stomach and the liver is known as the lesser omentum. Then we also have the greater omentum. And then we can see some falciform ligament. Actually, it's not a ligament, but we call it ligament because it attaches to the body wall. So the falciform ligament connects the liver to the external body wall. So this is just to show a lateral view of the presentations of what the organ. So if these mesenteries were not in place, you will be moving and then all the intestines will be moving in different directions. And then maybe the food you eat will not even have any or adjustable sections to move through, impeding their work and hence making you to not survive. So I've already explained this. We have the greater omentum, connects the stomach to the posterior abdominal wall, and then wraps around the spleen. And then the one that wraps around the spleen, we call it the gastrosplenic ligament. Gastro, you know, gastro means stomach and splenic means spleen. So I told you anatomy is not any difficult course. It's just words that are put together. So gastrosplenic ligament, and then it continues dorsally as the splenorenal ligament. So splenorenal ligament means that it moves from the spleen to the kidney. Then it has a lot of fat, and then it limits spread of infections. That's one thing about the greater omentum. It limits the spread of infection by wrapping around inflamed cells, especially when you have appendicitis, so that it doesn't get to the other organs. But when it is left unchecked for over a long period of time, it can do that. The mesentery proper is the one that go around the jejunum and then the ileum. Then we can also have the mesocolons. We can have the transverse mesocolon, the sigmoid mesocolon, and the ascending mesocolon, the descending mesocolon. So when you see the transverse mesocolon, the main ones are the transverse mesocolon, which will connect the transverse colon to the posterior abdominal wall. And then the sigmoid mesocolon will connect the sigmoid colon to the posterior abdominal wall. So this is just to show us the greater omentum. And then these are all the mesenteries. And then you can see the spleen. So we have the gastrosplenal ligament around this area. And then this is the liver. So the liver also has something we call ligamentum teres, which will connect the liver down to the ventral mesocolon. The greater omentum is here. And then the lesser omentum is actually at the back there. So if you want to know the difference between the greater omentum and the lesser omentum, let me use this picture rather. The lesser omentum will connect the concave surface of the stomach to the liver. And then the greater omentum will connect this convex surface of the stomach to the abdominal wall. So this is just to show us the greater omentum, and then we can see the transverse mesocolon, and then we can see the sigmoid mesocolon, and then the mesentery. We call it mesentery proper when it is connecting the small intestines, whether the jejunum, the duodenum, or the ileum to the abdominal wall. Now, some organs are also retroperitoneal. That means behind the peritoneum. Let's look at it. So any organ that is found itself around this area, we call it the retroperitoneal space. So some of these organs, let's look at them. The kidney is one, I've mentioned one, okay? The kidney is one. So they are behind the peritoneum. They are fused with the posterior abdominal wall. And then here, there is no mesentery because you don't find the ileum, the duodenum, and the jejunum in the dorsal cavity of the body, or they are nearer to the ventral cavity. So they lack mesenteries. And then some of the organs we can see here are the ascending colon, the descending colon. That is how come we don't have mesocolons for ascending and descending. Rectum too is also nearer to the retroperitoneal cavity, the pancreas too. So normally, if you have any pain coming from this section, they tend to cause back pain instead of abdominal pain because they are found in the retroperitoneal cavity. So if someone is complaining of back pain, it will not be only the muscles that are actually involved. You can actually have pain from the duodenum that is kind of cruciating to the back. And you could also have ascending, descending colon, the rectum, and also some pancreas. But when you are having the ventral surface abdominal pain, then we should be looking at your jejunum, the ileum, the transverse column, and the sigmoid column. So now let's begin the GIT proper. So we are looking at the oral cavity, which contains the tank, which is a skeletal muscular organ. And then within there at the back of we have the tonsils, which are responsible for checking any form of infection within the food. That is why when you have tonsillitis, swallowing becomes very difficult. Swallowing becomes very difficult. And then we have the masticating muscles. I would want you to go and find out what the masticating muscles are. So this is just an opening of the oral cavity. We can see the uvula, and then we can see the soft palate and then the hard palate. This is the muscular organ, the tank, which takes bulk of the oral cavity. And then there's some of the frenulums, the teeth, all these things are involved in the mechanical digestion of the food. So we're also looking at the tank. The tank is differentiated into two parts, the anterior third and the posterior 1/3. The posterior 1/3 is made up of a lot of lingual tonsils. And then beside them, we have the palatine tonsils. And then at the back, we have the posterior tonsils. And then what we are seeing here is the palatopharyngeal arc, which connects the palatine tonsils all the way to the epiglottis, which covers the glottis whenever you are swallowing food. So on the anterior 2/3, what we are actually seeing is basically the papillae. Those dot things that you see are papillae. Most of them are filiform papillae. And then scattered among these filiform papillae are the fungiform papillae, which are also having some form of taste buds that will sense some form of sweetness in food. Then we have circumvallate papillae, which are actually found at the junction between the anterior 2/3 and then the posterior 1/3. They also have taste buds. Go and find the taste that the taste buds of the circumvallate papillae will detect. The teeth or dentitions is the total number of teeth that you have in the oral cavity. What is the dental or the dentition of a human? Who can tell me? Hello.
32.
32.
Yes,
Based
sir.
on the displacement, can you explain how these 32 teeth are arranged within the oral cavity?
Okay, so I can try to remember.
Oh, don't worry. Just try and remember.
So we have upper incisor, and then the lower incisor. We have the upper premolar and upper molar. We have upper canine, and then lower canine. We have the molar, the upper molar and the lower molar, and then the arrangement is 2, 1, 2, 1, 3. So I forgot the formula.
Okay, all right. You did well. So we are just looking at when you take, he's actually looking at half of the side. Okay, so we all know this formula. I don't have. When do we start learning this thing? Is it in JHS or class what? I thought I learned this thing from class 5 or 4.
Class 5.
Yes. So please, if you misplace your class 5 notebook, go and look for it. Okay, let's continue. So go and look at the dental formula of humans. Okay. So this is just to show. Why did I even put this thing here? Sorry. Anyway, it's already here. So depending on your age, it determines the dental formula also within the mouth. So we have 2 sets. We have the deciduous teeth, and then we have the permanent teeth. So the deciduous teeth are the baby teeth, the ones you eventually change well when you're about 6 years. It starts around 6 months, and then 20 are out by the age of 22 years, and then they begin to fall out between 2 to 6 years. And then we also have permanent, which are 32. So if you are old now and you lose your teeth, there's no way you can get it back. Forget. There's no way you can get your teeth back. So take care of your mouth so that you don't go hit it with anything. And then for the permanent one, which is 32 in total, even some of you now, you don't have the 32. A time will come, you still have some pains around the cheek region, and then it tells you you have the third set of teeth coming out, which we call the wisdom teeth. So all but the third set of molars by the end of adolescence are out, and then some can be embedded within the bone. So we call them the impacted teeth. So these are the molars. These are the premolars. This is the canine, and then these are the incisor. So 2, 1, 2, 3. Are you okay now? 2, 1, 2, 3. So that will make 8 here, 8 here, 16, and then the same thing at the top or down, and then that gives you 32. So I already explained the classifications of the teeth. You have the incisors, canines, premolars, and the molars, and then you know what they do. And one thing about the teeth is that we have the teeth actually more embedded into the gum. So the teeth has a root where you cannot see, okay, which is embedded within the gum, and then you have the neck region, and then the crown where you have the enamel. So the enamel is made up of 99% of calcium, and it's the hardest substance in the body, not even the bone. So the enamel is the hardest substance. That is how come you can use it to break bone, but you cannot use bone to break the enamel. And then the dentin is the bulk of the tooth, which is actually embedded within the harder bone. and then we have the root over here. So all this part is the bone, and then the tooth is actually embedded within it. So the cementum is actually the bone layer of the teeth. Okay, so the bone layer of the teeth root, and then it actually attached to the bone by what we call the periodontal ligament. The periodont. So these are the periodontal ligaments. So the periodontal ligaments will connect the roots of the tooth to the bone. So normally plaques are formed around this area when you have films of sugar, bacteria, and debris of overnight eating. That is why it is very essential you brush your teeth before you sleep. Now, the next other thing, so now we are done with the saliva, the GIT, we are looking at the accessory GIT system. So the next thing is the salivary glands. So the salivary glands, we have the intrinsic salivary gland and then the extrinsic salivary glands. The intrinsic salivary glands are within the mucosa. They secrete the saliva all the time to keep the mouth moist. The extrinsic salivary glands, we have 2 pair each. We have the parotid, submandibular, and sublingual, and they are the main salivary glands. Now, saliva is actually a mixture of water, iron, and mucus, enzymes that will keep the mouth moist and also divorce food substances in the mouth. So this is just to show us the parotid gland. At times you eat something and you feel like this side is paining you near the ear. It means that your salivary gland is trying to secrete inaction to that food and then it doesn't like it. So that is the parotid. And then the one below the tongue is known as the sublingual. And then the one below the jaw is known as the submandibular. So as you can see from here, you can see that they have some brain connections to the mouth. These are the ducts. So this tells us that the salivary glands are exocrine glands. Exocrine glands. Class rep, can you put that person in waiting room for me? Thank you very much. I hope it is done, Chronicles.
Yes, sir.
Thank you. Let's continue. So the parotid glands are the largest, and then they have the facial nerve, which is the 7th cranial nerve, which branch into it. So normally, if you are not careful and we are doing surgical operations, and then you tend to work on the parotid gland and you don't take care, you cut the facial nerve. And when you cut the facial nerve, the person will suffer from muscular ptosis of the face. So the face begins to droop. Then we also have the submandibular, and we have the sublingual under the tongue. And then the salivary glands are usually compound tubulo-alveolar glands. Please, histologically, they are what? Compound tubulo-alveolar glands, especially the parotid gland. Pharynx. So the pharynx, as I said, is the space behind the oral cavity, which connects the oral cavity to the nasal cavity and then to the larynx. So it has 2 parts, the 3 main parts, the oral, the laryngeal, and then the nasal pharynx. They're actually connected to all these muscles, which are skeletal muscles. Some of these muscles, we have the superior pharyngeal constrictor muscle, the middle pharyngeal constrictor muscle, and then the inferior pharyngeal constrictor muscle. So they all constrict the pharynx. We can also talk about the malohyoid, the genihyoid, and then all these things will form an aspect of the pharynx. So we are the esophagus. All we need to know about the esophagus is that it's a muscular tube which connects the oral cavity to the stomach. And it is made up of 4 layers, as I described earlier, looking at the mucosa, the submucosa, the muscularis externa, and then the adventitia. The esophagus is actually in the dorsal cavity, body wall, and then it is posterior to the trachea. So normally when you cut the trachea, you cut the esophagus at the back. So it is posterior to the trachea and anterior to the vertebral canal. Below the esophagus, we have the stomach, and then the stomach is connected to the esophagus. Between the two, we have something we call the cardiac sphincter. And normally this cardiac sphincter will prevent the regurgitation of food back into the esophagus. When that happens, then you suffer from something we call cardiac heartburns. We call it heartburns. When you finish eating, you say, oh, I have heartburns. It's not actually that your heart is burning, but just that the acid within the gastric organ is so much for the esophagus mucosal lining. So it bends it and it gives you that sensations. So you are suffering from something like this, you can go and take new gel and then you will be fine. So this is just to show the esophagus connected to the stomach. The stomach has the esophagus is also about 2 centimeters long. As I explained, we talk about the cardiac sphincter already, and then between at the cardiac sphincter region, the mucosa is made up of something we call the gastroesophageal junction, and this will be taught in histology, where we call where there is a change in epithelium from stratified squamous non-keratinizing to simple columnar microfilated epithelium. And then this is where the esophagus will pass into the abdominal pelvic cavity, which we call the esophageal hiatus. Esophageal hiatus. Hiatus simply means opening. So this is just to show histological display of the esophagus. I'm not going to talk about this. This will be done in the functional histology section. Stomach. J-shaped, widest part of the alimentary canal, and then it does temporal storage and mixing of food for 4 hours into chyme. Emmanuel, you can ask your question.
Yeah, so please, I want to ask whether gullet is still right to be said instead of esophagus, like the 2 words.
Come again, I didn't hear you.
I said that, can we still say gullet? Like, is it right to say gullet?
For esophagus?
Yes, sir.
Use the right term, which is esophagus. Gullet is a tubular connection of the gut. You may mistake that for other, yeah.
Okay, sir. Yeah. And I also want to ask, at the thoracic region and the abdominal region, you see, we have the diaphragm.
Yeah.
Below the heart. So I want to ask, when the gullet, the esophagus, is it posterior to the diaphragm, or like where does it pass because of the diaphragm?
Come again.
So can you hear me?
Yeah, I can hear you. Come again.
Yeah, I said that the esophagus. See, we have the diaphragm in between the thoracic and abdominal part of the body. So I'm asking if the esophagus is descending, where is posterior to the gullet, or is it posterior to the diaphragm, or I don't know what happens there.
Oh, the esophagus actually passes through the diaphragm. That was what I was showing you earlier. Yeah. You see the esophageal hiatus. It passes through the diaphragm into the abdominal cavity. This is a diaphragm. Okay. So the esophageal hiatus is an opening in the diaphragm where the esophagus passes from the thoracic cavity into the abdominal cavity. Are you okay now? Hello? Hello?
Yes, sir.
Are you okay now?
Yes, sir.
All right, so let's continue. So when we take the stomach, I've already explained this heartburn something. And then most nutrients wait until they get to the small intestine. But some water and electrolytes are absorbed from the stomach. And some drugs such as aspirin and then alcohol are also absorbed from the stomach region. So it also explains how there could be some form of a bit of hepatic bypass, okay? But most of the connection is from the stomach. So most of the alcohol is being checked by the liver. So this is just to show the epigastric layer. And then this is the hypogastrum layer. So this is the right upper quadrant and the left upper quadrant together with their lower quadrant. So it actually lies mostly in the stomach is actually mostly in the left upper quadrant. And then, but pain can be epigastric or lower. That means it can give pain to the liver or to the back and then to the intestines in case the stomach is in problem. And it is just inferior. You can see this is the diaphragm over there. Okay, the diaphragm is here and it's a bit inferior to the stomach. The stomach is inferior to the diaphragm. And then the stomach is anterior to the spleen and pancreas. And then it has these main regions, as we can see in the drawing over here. So the stomach is also placed into this part. We have the fundus, the body, and then the pylorus, and then the cardiac region. So this is the cardiac, the fundus, the pylorus, and then the body. So the pylorus region will have the pyloric antrum and then the pyloric canal. And this is the main pylorus. And then the stomach itself will have the lesser curvature between the esophagus and then the pylorus. And this is the greater curvature. Please go and read on the blood supply and to the stomach, how blood gets to the greater and lesser curvatures, and how blood is drained from this. It may be one of your questions. So this is just to put or to show pictorial section of the abdominal pelvic cavity showing the greater omental bursa. So you can see the stomach, there's the fundus region, the cardiac region, the body, and then the pylorus with the lesser omentum. There's a lesser omentum, and then this connects, this particular lesser omentum part connects to the liver by what we call the hepatogastric ligament. And the one that will connect the liver, the stomach, the liver to the duodenum is known as the hepatoduodenal ligament. So the hepatoduodenal ligament will connect the liver to the pylorus. So the hepatogastric ligament and the hepatoduodenal ligament make up the lesser omentum. And then the greater omentum, we can is connecting the greater curvature to the body, anterior body wall. Within the greater curvature, we can look at the right gastroepiploic arteries, which will supply the greater omental bursa. I've already spoken about this, so I'm not going to talk more about it. So this is just to show how the internal surface of the stomach is placed. This is just to show us the rugi, that's the folding of the internal mucosal surface. The A's have already seen how these things are well presented in the functional histology. So this is just to show the rugi. After the rugi, which is a fold of the mucosa, after that we have the muscularis, and you can see the inner oblique, and then the middle circular, and then the outer longitudinal layer. So this is just to show histology. I'm not going to talk much about it. The only thing I'm going to mention is, because it is digestion, I'll mention some of the cells. So the mucosa is thrown into folds which are known as the rugi, and within the rugi we have the gastric pit. Now it has the surface epithelial cells, and then in the neck of the region we have the mucous neck cells, which are this. Within the mucous neck cells, we also have specialized cells, which are the parietal cells, or the chief cells, which are responsible in the secretion of all HCl. So you can see this is the parietal cell, which will secrete HCl that will be released to the surface. And this HCl will convert the inactive pepsinogen to active pepsin, which is going to work on the protein aspect of digestion. And then these are enteroendocrine cells, or stem cells, which are responsible for. So you can see the mucous neck cells, we have the parietal cells, and then it also is an intrinsic factor for vitamin B12 absorption. And the chief cells will convert the pepsinogen, they produce the pepsinogen. And then the pepsinogen will be activated into pepsin by the product of the parietal cells, which is HCl hydrochloric acid. And then they also stimulate the secretion. They are stimulated by the secretion of gastrin, which will also work on some of the things inside it. The stomach, the small intestine is the longest part, about 2 to 5 meters, very long. And this is where we have most of the enzymatic digestion occurring, and almost all absorption of nutrients is happening here. Happens in 3 to 6 hours, runs from the pylorus to the ileum, that is right lower quadrant of the cell, where it is connected to the large intestine by the ileocecal junction. So within the small intestine, we have the pancreas, and then the contents of the gallbladder being secreted into the duodenum. The content of the gallbladder will be secreted by the cystic duct into the bile duct. And some of this, the right and left hepatic duct of the liver will also secrete their content of bile into this. And then the bile will now meet the pancreatic amylase at the hepatopancreatic ampulla. Now, the pancreatic amylase is also going to pass through the main pancreatic duct and then be released into the duodenum. When this is done, we are going to have the emulsification of fat and other things happening in there. So this is actually done at the second part of the duodenum. So the folds of the ileum, that's the villi of the ileum. For now, I know you are very much enthused about, or let me say, very much conversant with the villi, especially the A's. I don't know for the B's. We know that within the villi, we have a lot of lacteals, which are some form of network of blood and lymph capillaries that are involved in the protection of whatever food material is going to be absorbed. This is showing us the simple columnar epithelium with the villi. You can see this, that's the villi. And these villi have a lot of microvilli on them, which will actually increase the rate of absorption. So the cut in this section is going to show absorptive cells within the microvilli to increase surface area and many mitochondria to enhance nutrient uptake for respiration. So the cells here divide every 3 to 6 days to renew the epithelium, most rapidly dividing cells of the body. They secrete watery intestinal juice, which mixes with chyme. And then they actually have something we call intestinal flora. These are normal bacteria within the cells, which will kind of manufacture some vitamins, especially potassium, for them to be absorbed. So normal flora of the body is also very needed. Now, what we have to know is that in the duodenum, we have mucus that counteracts the acidity from the stomach, and some hormones such as the cholecystokinin, which we always call CCK, will stimulate the secretion of bile to be released from the gallbladder and also the pancreas. And then also secretin, which will stimulate the pancreatic duct to release acid neutralizer. So these are the things that will happen within the duodenum. So this is just to show us more of the villi within the duodenum, and then the microvilli on top of it. So this is showing us how these villi will look like. And then this thing that we see, fold into it, this whole thing is known as the plica secularis. The plica secularis. So this is a plica secularis. This is a plica secularis. On top of this plica secularis, we have the villi. And on top of each of these villi, we have the microvilli. Now you can see how blood vessels and things from the submucosa will go all the way into the plica to allow for. Now, this yellow thing you see here are the Meissner's plexus or the submucosa plexus. And then the one between the inner circular, the interlongitudinal, are known as the myenteric plexus. So you can see the myenteric plexus. And then after that, we have the serosa. So this is all that I was trying to show in there. Now, for the colon, the colon does most at the colon, we don't have any absorption of nutrients. Mostly it is water absorption and the formation of feces. And then this is just to show the greater omentum coming from the stomach to hold up. So this is actually going to form something we call transverse mesocolon. And then this is the descending colon, this is the ascending colon, and this is the ileocecal valve. At this patient issue, we have a junction also via which we call the ileocecal junction. And then this is the appendix, which is rudimentary in humans. Then this is the sigmoid colon and then the rectum. I don't have much time to talk about the blood supply. It's all over here. You can still read about it. So from the inferior vena cava, we can see the inferior mesenteric artery branching into the left colic artery. And then this left colic artery, a lot of them will eventually branch to form wherever it found itself. So those that will come to the rectum will be known as the rectal artery. And then those that will come to the sigmoid colon will be known as the sigmoid artery. And then those that will come to the veins here, we call them the mesenteric transverse colon arteries. So depending on how the blood vessel branches profusely to invest in them, the names are given as such. And then one thing we also have to know is that you can see how these things are posed into this kind of foods. We call them the hostria. And that is how your fecal matter is actually released from the rectum in sections, okay, into bolus sections. So as we are having left inferior mesenteric artery, there too, we are looking at the middle colic artery and its vein. And then we can also look at the superior mesenteric artery. So you can see the superior mesenteric artery is coming a bit above the transverse colon, while the inferior mesenteric artery is below the transverse colon. So this makes anatomy, telling you how blood vessels will go in, how nerves will also come in place. So looking at this, I say most of the function here is to absorb water and some electrolytes. And then this is the transverse mesocolon. This is the superior mesenteric artery inside the omental bursa. So we can see the ascending colon and then the descending colon, the sigmoid colon. And then one other thing is the anal canal. Within the anal canal, we'll be looking at the internal anal sphincter and then the external anal sphincter. So as I said, in the colon, we are going to see some things, the hostra, which are packing into sacs, the epiploic appendages, which are the omental bases. So this is just to show epiploic appendage, and this is showing the hostra. I think there's a question in the chat region. Let me read that and then we continue. Sir, can there be a case where the bowel would mix its way into the bloodstream? No, please, because the bowel, when we look at this, let's go back a bit. Where is that in? Yeah, so you see the bowel will actually get into the bowel duct and then join the pancreatic duct to form the hepatopancreatic ampulla, which will be released into the duodenum. So it has nothing to do with the blood vessels. Unless there is some form of cancer, then even that, it is a bit difficult. So this is just to show the histology of the large intestine with a lot of those whitish substances known as goblet cells. The E's have already seen these things, and which are involved in the secretion of mucus to lubricate the stool. And then here you do not have villi, but there are some microvilli in there. So the next thing we're going to talk about is the liver, which is the largest organ in the body. Over 500 actions, we cannot talk about them now. And then the main thing anatomically we have to know is that the liver is made up of two lobes, the right liver lobe and then the left liver lobe. Between them, we have the falciform ligament, which connects the liver to the anterior body wall. And then we have the round ligament, which we call the ligamentum teres. So we have the falciform ligament, which is a mesentery binding the liver to the anterior abdominal wall. And then the liver has two surfaces. We have the diaphragmatic surface, which is on top over here, which faces the liver. And then we have the visceral surface, which is at the back, which faces other internal organs, or also here, which faces other internal organs. The liver is actually covered in peritoneum, except the aspect that is connected to the diaphragm. Now, within the liver, we should talk about the portal hepatis, which is a major vessel and nerve enter and leave the liver. So this is the portal hepatis. And then within the portal hepatis, we can have some blood vessels also coming in there. So this is the ligamentum teres. And then this is the quadrate lobe. The liver has right lobe, left lobe, caudate lobe, and then the quadrate lobe. So the main lobes are the right and the left, but we also have the caudate lobe and then the quadrate lobe. The ligamentum teres is between the left and then the quadrate loop. And then you can see the lesser omentum from the stomach. Okay, the lesser omentum. This is just to show how you can start counting the ribs and how they are associated with the organs. So the ligamentum teres is actually a remnant of the umbilical vein in fetus, which attaches to the navel. Okay. So this is the umbilical vein, and then in an adult, this will connect. This actually changes into ligamentum teres. You can see the umbilical vein is gone, and it changes into ligamentum teres, so that it doesn't do anything. And this connects to the navel, but this is actually connecting to the placenta. So this is just showing us fetal circulation, and this is showing us adult circulation. So this here, you see how the blood will move into the placenta, which takes the action of the lungs. You can see that here we are showing immature lungs. Blood doesn't move into the lungs, but here blood moves and out of the lungs. So pictorially, this is just showing us the hepatic portal vein, which is the main site for checking where substances get into the liver. Someone might think that deoxygenated blood is found within here. When we find a type of blood that will be found in the hepatic portal vein. And then this whole thing is what we call the hepatic triad, the portal triad, which is made up of the portal vein, the hepatic artery, and then the hepatic duct. We'll be seeing this histologically in functional histology later. Some liver repertoires, we are looking at produces biopic glucose from the blood, stored glucose as glycogen, processed fat, and amino acid, store some vitamin, detoxify poisons and drugs, and make blood proteins. Liver histology, I'm not going to talk about it over here. When you do hepatic histology, you'll get to understand that. So this is just a bit of it. The central vein, and this is the hepatic lobule, all this thing, which is made up of the hepatocytes. The hepatocytes are actually hexagonal solid cells. So you can see 1, 2, 3, 4, 5, 6. That's hexagonal around the central vein. All these things here, inside here, hepatocytes. So this is just to showing us the portal triad, which is made up of the hepatic portal vein, and then the hepatic artery, and then the hepatic duct, which will send on the information through the canaliculus. You can see over here, through these pinkish things over here, which are the hepatic canaliculus, or the sinusoids, which will release they are the sinusoids, which will release their main substance into the central vein. And then the central vein now takes the information and enter into the interlobal veins. And then it gets to the hepatic vein, and then gets to the inferior vena cava. So this is just to show us a superior version of this. You can see the portal venu, the portal arteriole, moving the information to the central vein and in and out. This is also the bile duct. Okay, how information, whatever is produced here will be moved into the bile duct, and then gets into the bile duct and meets the pancreas at the hepatopancreatic ampulla. Now within the sinusoids, we have something we call the Kupffer cells or the Kapfer cells, and then they are actually liver macrophages, and then old blood cells and they are able to remove old blood cells and microorganisms. That is why we say the liver is responsible for breaking down of what? Old blood cells and converting them to blood proteins, such as some bilirubin and bilirubinogen, which are stored in the liver. for that. So I've already explained this hepatocytins already. Gallbladder. Gallbladder actually is just a storage organ. And then bile is excreted into the duodenum when it is needed for fatty meals, for emulsification of fat. And then the bile will help dissolve fat and cholesterol. Now, if the bile is not processed well and used, and it crystallizes, then it forms something we call gallstones. And then those are very, very dangerous. They give intermittent pains, and then they can also be caused actually from infections and other stuff. So this is just to show the contents of the left upper quadrant. Left upper quadrant. And the other thing we are looking at now is this curve-shaped organ, which is the pancreas, okay, which is the pancreas, which contains the main pancreatic duct, which will receive their secretions from the acinal cells of the pancreas or acinal cells of the pancreas. While that is the exocrine part. But the endocrine part, we are looking at the beta islet of Langerhans, which will secrete insulin, and then the alpha cells secreting glucagon for whatever actions they want to perform. So this is just to show us blood supply and then drainage. So you have the abdominal aorta. At the abdominal aorta, you have the splenic artery coming out. And then the splenic artery, at this side, you have the superior pancreatic artery, which will also come and give some form of blood supply to the pancreas. And then from the splenic artery, it also gives the great pancreatic artery, which connects the splenic artery to the transverse pancreatic arteries, which are branches of the superior pancreatic artery. Then from the common hepatic artery, there is a branch which is the gastroduodenal artery. And then the gastroduodenal artery eventually at the pancreatic region takes the name as pancreaticoduodenal artery. The pancreaticoduodenal artery, which gives branches to the duodenum and then the pancreas. So this is how the stomach, the pylorus of the stomach, the pancreas, and then the duodenum are supplied with blood. So I've already spoken about the acinal cells, which are exocrine, and then they make 22 kinds of enzymes which are stored as zymogens in the granules. And then the islet of Langerhans, we have the insulin from the beta cells, and then the glucagon from the alpha cells. So when you look at the pancreas, eventually you should be looking at something like this, which are more of the acinal cells, which are more than the islet of Langerhans. And then the glucagons cells, that's the alpha cells, they stay more reddish. And then the beta cells will stay more violet. And then you will see them in the whole thing here are the islets of Langerhans. But this, you don't see this kind of, we'll be seeing these things eventually in the gastroduodenal histology. So this brings us to the end of the gastrointestinal gross anatomy. Any questions? Any questions? All right. Let's see. Chronicles, are you there?
Yes, sir.
Who is Awiye Alfred Amenyu? And then I'm just trying to take Precious. Is Precious here?
Yes, sir. Please, I'm here.
Okay. And Prisla. Okay. Chronicles.
Sir.
Take note of these people that are here for me quickly.
Okay.
I'm not using this as any, but I'm just taking note of them for any future release. So just take note of them for me.
I'm done.
Okay. Thank you very much. How did the lecture go? I want to ask all of you.
It went very well. It was very smooth.
Yeah.
No disturbance. Everything was fine.
All
It was
right.
just great lecture.
Okay. So what is going to happen is that because of the issues we had pertaining to the lecture time, I'm doing this. Now I'm going to upload this on the YouTube channel and give the link for as a pre-recorded lecture for those who would want to watch it. So Monday, there will be no lecture. Do we get that? Because I don't want to have any disturbance when it comes to the network. And that time, I may also be in the house. Getting to school before doing the lecture might be a problem. Do you understand that? So I thought it wise that we'll do it like this. Do we get that?
Yes, sir.
Anytime we may be having online, I may be doing this on Saturdays. Do we understand?
Yes, sir.
All right. Winifred, how are you?
Fine, thank you, sir.
Okay. Maureen, do I know them? I want, let me see your faces. Maureen, let me see your face. I want to know them. Alfred, is that your picture there? Alfred, is that your picture? Oh, okay. I've seen Maureen. Maureen, you came to mark the last time, right?
Yes, sir.
Okay, okay, that's beautiful. Thank you very much, Maureen, for the service. Joshua Ofori, can I see your face? The light is poor, eh? Oh, okay. I can see. It's okay. Prisla, who is Prisla? Where is Prisla? I'm sure maybe the network is disturbing at Prisla's end. And Winifred, and upon, if you cannot just show your face, let me just see that with me. Okay. I'm now taking note of. I can now see the people. Oh, Winifred, how are you? Nyako, is that your face? Nyako is my TA. That's my TA. Okay.
Mr. Bruni.
All right. Okay. So thank you very much for making it for this section of lecture. I wish you all the best. And so,
I wanted to ask a question.
Okay, you ask your question.
Yeah. You see, in a case whereby, like after eating, Sometimes you I don't know if it's a reflux. Some of the food will get up into your the walls of your esophagus. But I don't know why. Sometimes you feel the pain in your heart. I don't know if there's a cardiac connection with that.
You see,
Like when you eat.
Whatever, you see, when you do something we call, anyway, the anatomy I'm teaching you is not for medical students, okay?
Okay.
If it were in medical school, I'm going to divide the thoracic section into different regions, okay? And then you realize that when there is a reflux of acidic chyme from the stomach via the cardiac sphincter into the esophagus, what happens is that you are going to have pain. Okay, the pain that you are having is actually because the acid environment is not good for the mucosal lining of the esophagus. The pH is less than 1, and the esophagus is not designed for that. So it burns up the mucosa of the esophagus. Now that pain is taken through the Meissner's plexus, and then it's given to the surrounding tissues. So because the esophagus is just lying at the back of the heart, it is also given to the heart, and the heart is so sensitive. So you feel it as what? A heart pain, a heart burn. But actually it is your esophagus that knows your heart, okay?
Okay.
Yeah. All right, so thank you very much. Have a wonderful evening and a precious evening as well. Bye-bye.
Bye.